Okay, once again, I'm back. The makeup artist didn't get here today on time, so my hair and makeup are not just suitable for this. Just really, they're not. Um, anyway, we're going to talk about sexuality, and this is going to include fun things like menstrual dysfunction, menopause, and erectile dysfunction. So we've got so many fun things to talk about. Here are your objectives for the day. Forget the October 30th um, date. I have absolutely no idea why it's there. All right, so don't be mad at me, guys, but I just really love this. The root of a woman's problems is mental illness, menstrual cramps, mental breakdown, menopause, a gynecologist. And when there is real trouble, it's a hysterectomy. Ever notice how all of women's problems start with men? So anyway, you don't have to laugh. I don't know, maybe you'll turn me in for it. I hope not, because I kind of thought it was funny. So this just goes back to your A&P, internal and external anatomy. Just some pictures here. Um, if I could show you with my arms, which let's see if I can do this. Back up, back up, back up, back up, back up in my office. Okay, so I'm going to stand up. Hopefully my head will still be in there. You won't be able to see my legs, but just imagine them down below me. I always think about the uterus and fallopian tubes and everything like this. See? My arms are the fallopian tubes and my finger are the fimbriae. All right. And my body is like the body of the uterus and my legs would be like the vagina. So that's how it kind of is. So if I see you during a test going like this, I'll know exactly what you're doing. You're trying to remember the anatomy of the uterus. But as you can see, we've got this uterus here. You can even see how muscular it is even when it's normal. We have, and ladies, I don't mean to make you feel like you are an idiot or anything, but I do like to mention this, and that is that there are 3 separate openings. All right, maybe some guys don't know this either, but you have the urethra, all right, which is where the urine comes out of. You have the vaginal opening, and you have the anus. So just if you don't know your anatomy, take a look because you really need to know it. It makes it a whole lot easier to do a urinary catheterization too. So physical changes start about 9 or 10 years old, and that depends on whether you are a male or a female. Typically, a female will begin to develop a little bit earlier. Females will develop their little breast buds. They'll start to grow hair, production of estrogen, so and then they will begin to feel a sexual attraction. Males do not develop breast buds typically, and they begin to produce testosterone from the adrenal glands. Sex characteristics. It's really important to know the difference between primary and secondary sex characteristics. This is likely an important slide. They involve, anything that's primary is going to involve reproductive organs. All right. So those are going to be your primary sexual characteristics. Your secondary sexual characteristics, you kind of think about it in terms of, you got the big boys, all right, like your uterus and, being able to get pregnant or being able to get somebody pregnant. And then you've got all these other little things that go along with it that are a result of all of these other big hormones. But in boys, the testes and scrotum increase in size. The skin on the scrotum becomes darker. Pubic and axillary hair grow. And nocturnal emissions begin about 13 to 15 years old. And then, of course, the voice lowers. Interestingly enough, and I guess God just does it like this, the girl's hips do begin to broaden, and that helps because she may have babies one day. Hair grows, vaginal secretions become milky, and she usually will begin her period, and that first period is called menarche. Menses is for menstruation. There is There can be menstrual dysfunction, and there are two types. There's dysmenorrhea and dysfunctional uterine bleeding. Now, with dysmenorrhea, it can be primary or secondary. Dysfunctional uterine bleeding is really totally something else. So just be aware of that as we go through, because they are not the same. Primary dysmenorrhea, it's common. Normal menstruation function, hormonal in nature, but pelvic pain. That pain, it's like your cramps at your cramps at your cramps at your diarrhea. That's what it is. It's cramps at your period. A woman may have a headache, nausea and vomiting, may not want to eat, or anorexia, some breast tenderness, and it's caused by the release of prostaglandins. I mean, there are so many hormones, and we think about hormones, and we always, we can blame things on hormones, but chances are it's the hormone's fault. Secondary dysmenorrhea is related to some kind of pathological problem, like maybe endometriosis, but there's something else going on. So you've got primary, which is pretty much normal. Secondary, there's probably something wrong. It does cause severe pain. The pain lasts longer than the regular dysmenorrhea, primary dysmenorrhea. It can be caused by endometriosis. There may be some kind of malformation, maybe tumors, maybe cysts, maybe pelvic inflammatory disease. So it's secondary dysmenorrhea is because there's some kind of pathologic problem. Risk factors, usually early age at menarche, less than 11 years old, long, heavy menstrual periods, smoking, and a family history. So smoking seems to be the culprit for so many things. And then we've got dysfunctional uterine bleeding, and this results from a disordered hormonal process that develops maturation of ovarian follicles. The bleeding happens, but there is no cramping with it because there is no progesterone. There's a loss of a complete shedding of the lining of the uterus. So there's stuff held up in there, and then heavy bleeding can be followed by long periods of amenorrhea. So this is very unusual. I haven't known very many people with dysfunctional uterine bleeding or patients, but it does happen. What's important is that you know the difference between what primary dysmenorrhea is, secondary dysmenorrhea, and dysfunctional uterine bleeding. The biggest thing is with dysfunctional uterine bleeding, there is no pain, all right? Usually is no pain. With secondary dysmenorrhea, it has something to do with a pathological condition, and with primary dysmenorrhea, it's just typically your normal monthly menstrual cramping. Usually occurs in the teens to early 20s. Sometimes those approaching menopause. Risk factors can include stress. Never underestimate the horribleness of stress. Extreme weight changes, obesity, thyroid disease, metabolic disorders, and certain birth control measures. We won't be getting into dysmenorrhea that deeply. Basically, it's going to be more about recognizing the difference between the different types of menstrual problems. But here are some good definitions. Amenorrhea means the absence of menses. Oligomenorrhea is light or infrequent. Menorrhagia is excessive bleeding. Menorrhagic is variable between menstrual periods. And menometrorrhagia, irregular, excessive, prolonged, and postmenopausal, usually caused by postmenopausal bleeding, that is usually caused by a pathological problem. Probably the most important terms there are amenorrhea and menorrhagia. because that will be that menorrhagia is that excessive or prolonged bleeding. The period can last for a long time, or while it does last, the bleeding is very, very heavy. Diagnostic tests that will be done: pap smear, pelvic exam, hysteroscopy, transvaginal ultrasound, which we talked about before, coloscopy, pregnancy tests, FSH and LH levels, progesterone, estradiol levels, and your thyroid stimulating hormone. Now, guys, the reason that they do all these tests is most usually because they're ruling out something. If they think they do all of these tests only to find out, well, thyroid stimulating hormone has nothing to do with what this problem is. So it's kind of like narrowing it down to, what is most likely the problem. For treatment, if you've got this, if you do have an endometrium that has remained in the uterus, it has not shed, they will probably go in and actually do an ablation, or just remove all of that extra or endometrial lining that's not supposed to be there. Sometimes they'll use oral contraceptives, but with the combination of the estrogen and progestin pills. So really, that's all there is to that. Electile, I'll tell you what, y'all, I need to go to bed. Erectile, erectile disorder is, they used to call it impotence. They don't really call it impotence anymore. They call it an erectile disorder. But this means that the male will have the inability to maintain an erection, or won't be able to get an erection at all. Sometimes he can, sometimes he can't. Sometimes the penis will lack rigidity, which makes it difficult to have intercourse. It can be linked to a loss of libido or sexual desire. This may occur just because of aging. Sometimes that doesn't affect it at all. Sometimes it's chronic, sometimes it's intermittent or situational. For instance, a man who's just lost his job, he doesn't feel like it, so he cannot get an erection. Sometimes it can actually be a neurovascular problem. In other words, nerves play a part in the erection. Also, vascularization plays a part, because there's this spongy tissue inside of the penis that will fill up with blood, and that's what makes the penis erect. Causes, again, the aging process, and collagen, loss of elasticity, loss of veno-occlusion, which allows the blood to flow out of the penis, resulting in a lack of rigidity. So the blood comes in, but it can't stay in there. So that veno-occlusion means literally that the veins would occlude to some point to hold that blood in the penis so that it would maintain rigidity. Loss of sensitivity, decrease in testosterone. And you've seen all of the advertisements out there that talk about buy this, these male pills and it'll fix everything. Typically, they don't work very well, and there's a lot of hype when there really shouldn't be. Chronic illnesses can also play into erectile dysfunction. Some of the blood pressure pills that a male will take can sometimes affect erections as well. But herein lies the basics, causes of erectile dysfunction. I said 8 groups. It only appears that there are 7, but they can be vascular, neurologic, urologic, endocrine, lifestyle, psychological, iatrogenic. So guys, basically the slide right before this is more important than this slide. So you've got a female nurse walking into an office or into a hospital room where a male is in there for something related to erectile dysfunction. Probably unlikely, but you confront somebody with this. or maybe a patient just opens up to you about something. It's very hard or it could be very hard for a male to open up about, erectile dysfunction. So you have to convey warmth and openness, and you want to develop that rapport. So really, sit down and don't stand up. And just talking back and forth, and saying, this is not that unusual. So you just kind of have to follow the patient's lead, because they're the ones that will guide you in terms of how you approach this subject. They'll usually take blood samples to determine your testosterone levels. Duplex Doppler ultrasonography. It looks like a vein. It looks at like the venous and the arterial blood flow through the penis to see if there are any kind of obstructions. Or nocturnal penile tumescence test, which never seen it done, people. Monitors nighttime erections. When positive, the cause is functional. So that's just a few ways to diagnose erectile dysfunction. Nursing diagnosis: sexual dysfunction, obviously, related to depression and conflict in relationships. I mean, because you've got to think that no matter, if you've got a relationship with someone and there's an erectile function problem, then it's going to make it difficult on that relationship. And then ineffective sexual pattern related to conflicts with sexual orientation. So, there's many reasons why individuals may have difficulty with erections. Treatment for ED is testosterone replacement. PDE5 relaxes smooth muscles in the penis to facilitate the blood flow. Viagra and Levitra will stimulate sexual erections. With Viagra, you have to be stimulated within a half an hour. Cialis usually is like 36 hours you have to, that it will work in terms of creating an erection. The PDE5 should be avoided when nitrates are needed. When they are taken together, there can be some severe hypotension. And there's actually a link here. I would, if I were you at some point, go ahead and watch this, because it's really hilarious, all right? But you'll never forget about nitrates, like giving nitroglycerin to somebody that's on Viagra. No, we don't want to do that. Other interventions are vacuum constriction devices, injecting the penis with vasodilating drugs, and penile implants. With a penile implant, they will actually put a little inflatable balloon, I guess, for lack of a different word, and then there will be a little pump that they will implant into the scrotum. And when an erection is desired, they actually will take that little pump and pump it up, and you're good to go. Sorry, I don't know how else to say it. And then we have menopause. This is the permanent cessation of menses. You don't have it anymore. There's a whole perimenopausal time, and this is when things are changing, and it's like your periods start to change, and then you kind of don't have them, and then you do have them again, or they're very either heavy bleeding or little bleeding, or you have them every 2 weeks, and then eventually they go off and off. They get smaller and smaller, the further and further apart. And then once there has been a whole year without any menstruation, you are considered to be postmenopausal, and everything's done. You never have to worry about it again. The average age is about 51, but that's average, so it can happen before and it can happen after that. Clinical manifestations of menopause: breast tissue, body hair, skin elasticity, subcutaneous fat, they all decrease. Although I haven't noticed my subcutaneous fat decreasing. What's wrong with me? Ovaries and the uterus atrophy. Probably going to be very difficult to get pregnant, although it does happen um, once you've gone through menopause. There's vaginal dryness, pain with intercourse, hot flashes, dizziness, palpitations, night sweats, eventual loss of menses, of course, and anxiety. Whew, I'll tell you what, that's a lot. And, we look at women at that age, and I mean, thankfully, I've gotten through it. But we look at women who are going through something like this, and we think they're absolute nuts, when in fact, they kind of are. But again, we go back to that hormonal influence and how it influences everything that happens in our bodies, both male and female. And it's a wonder that we all aren't in the loony bin. So the treatment for menopause will, when we say treatment, you can't get rid of it, but you can make it easier to go through it. Sometimes there's hormone replacement therapy, um, but the newest studies have shown that these hormone replacement therapies contributes to some cardiovascular problems and maybe even breast cancer. Um, but low dose estrogens can be used, and then selective estrogen receptor modifiers can also help. So, and antidepressants. One antidepressant called Effexor, venlafaxine, or I'm not sure exactly how to pronounce that, but Effexor will actually help with anxiety, but it will also help with to decrease hot flashes. So there are treatments out there that can be used that will help, not necessarily made to treat menopause, but will help get through some of the symptoms of menopause that can be really uncomfortable and hard to deal with. Some non-pharmacological treatment: massage, meditation, foods containing soy or simply soy, and ginseng. And these are really, I mean, exercise, all of the things that you do that keep you healthy are things that will help you move through menopause or perimenopausal symptoms a little more, a lot smoother. As far as the nursing process goes, you have to find out what the patient really knows or doesn't know about the process, any of these things that we've talked about in this particular video. But deficient knowledge, we think we know something, but we really don't. Sexuality pattern, um, which is ineffective. Situational low self-esteem. I mean, as you age, when your body does change, you start looking at yourself and this old girl just ain't what she used to be. There is a song that goes like that. But you've got to promote a healthy lifestyle. You've got to promote a healthy sex life, because older people still do have sex. A good body image and good self-esteem, because we got to realize that who we are is not what we look like. It's who we are inside. So that pretty much ends up that piece of all of those fun things like dysmenorrhea and erectile dysfunction and menopause. Um, so I will continue to keep in touch with you and probably give you an assignment, a discussion board kind of thing like we did before, just to kind of as an attendance sort of thing in the class. That'll be the way that we have to take attendance, because there's just so you know, guys, there's all kinds of proof that we have to have that we've made contact with you and that you're making contact with us. So this is how we're going to do it, and that way we don't have to bring you back in the summer. I don't want to come in the summer. All right, y'all, have a good evening.